Okay, so I want to step through a couple of slides from our product deck, just to illustrate what we've been up to lately and how the system works. So this is a diagram of Kelvin. It's essentially an ecosystem of modular components that allow one to define any kind of data capture protocol, capture that data either through a web interface or through mobile applications such as Kelvin Clinic, which is a clinician-facing application, or Kelvin Reach, which is a patient-facing mobile application. And then all data gets automatically uploaded to Kelvin Cloud. And then we have a machine learning pipeline called Kelvin Cortex, which I'll talk about in a minute. So to focus first on the data capture, the flow is that you can define any kind of form in the multimedia form builder, could capture video data, audio data, could capture patient-reported outcomes of some kind, a questionnaire. It can capture data from the Apple Health on an iOS device, or from Health Connect on an Android device, and automatically upload that to the cloud. So fairly flexible. Those data capture events, or continuous or episodic, happen through the mobile applications, as I mentioned, Reach and Clinic, and then all the data gets uploaded to the web application, Kelvin Cloud. And then the second component is Kelvin Cortex. This is a machine learning pipeline, which essentially allows you to utilize and or build your own models with the data or on the data that you've captured through the rest of the Kelvin platform, through the data management tools. So the engine that powers Kelvin Cortex is called Barlow. It's a biobehavioral foundation model. It's trained on, it can be trained on any kind of relevant data. Could be imaging, LFPs, kinematic data from video, from accelerometers, and so forth. But the idea is that it's pre-trained on large multimodal data sets, and then can be put to a particular use. And that's the fine-tuning stage. So we might have patient stratification, closed-loop programming, treatment response prediction. These are just some examples of applications that we might want to fine-tune Barlow to. So basically, the overall logic is to have this data infrastructure for capture and management in the form of Reach, Clinic, and the Form Builder and Kelvin Cloud, to build up these foundational data sets with which we can then build this model factory powered by Barlow, our or biobehavioral foundation model. Then we can use that to create any kind of specific use case model or application, deploy that and get feedback from it, which we can then use to modify whatever protocols we're capturing our data with, so as to optimize this process. It's supposed to be a kind of virtuous loop. So this is a nuts and bolts example of a piece of work that we're doing with a big customer, top 10 pharma, that have several assets in MS. We have large data sets in movement disorders, almost all video with high quality clinician ratings. We're able to take those data sets from different conditions and train a version of Barlow called Barlow K, which is the K for kinematic. So this is a specific instance of Barlow that has been pre-trained on very, very large data sets of kinematic data. So it's essentially learned the dynamics of human movement in both health and disease. And we then take that data set, take that model, and we can provide it to the customer who have a small data set in multiple sclerosis. And with it, they can fine-tune Barlow K in order to achieve a performant kinematic assessment model in multiple sclerosis, and they're going to deploy that into their clinical trials to use as an endpoint and a decision, essentially a decision support tool in trial design and developing these therapeutics. Things get even more interesting when we look at the possibility of actually in the next stage of development, which is to develop Barlow MS, whereby we take not just kinematic data, but all sorts of other clinical data, say medical history, imaging data, wearable data, speech and language data, cognitive data from tests or other kind of relevant information, and then of course the kinematic data that we've been developing with the customer ourselves, and with this we're able to build a system that essentially forms an embedding, a disease specific embedding for MS, and this allows us to place any patient in a space, a low dimensional space known as a latent space. Here we can see patients. This is simulated data, but the idea is in MS we might have 3 different groups of patients, the relapsing, remitting, primary progressive and secondary progressive patients, and we could cluster them within this latent space. And then even more interestingly, over time we would see each patient following trajectory as indicated by these arrows, and with these trajectories and these this latent representation, we can then ask some very interesting questions, such as, is the therapeutic that we're dealing with a symptomatic treatment or a disease modifying one? And we have some quite well established characteristics of disease modifying versus symptomatic. For example, for symptomatic treatments, we expect the trajectory to deviate initially, to have a small deviation from the control group, but then to converge with the control group after that. Whereas for a disease modifying treatment, we expect the patient state, the patient point, to diverge from the control group, either by slowing or halting or going into reverse, or in some other sense entering a less severe zone in the latent space. So I'll just finish up with a video that we created for a customer. Here we are. So this is a customer that has a disease modifying or putative disease modifying treatment. This is a patient who is off medication in both situations, but one pre a surgical intervention for a cell-based therapy, and the other on the right hand side post intervention. And what we're doing here is we're using our kinematic analysis, which has been based on a model trained through the Barlow framework that I described, where we fine-tuned it to assess PD symptoms in particular. And what we're showing here is algorithmically the model is able to detect the difference between the patient's clinical condition pre-surgery and the patient's clinical condition post-surgery. And in the top left and top right, we're accumulating the scores from each item as the algorithm provides them. And then in the middle at the top, we're showing the delta between pre-surgery and post-surgery. And over this small number of items, I think 10 or 11 actual assessments here that we do, you can see there's a relatively large delta accumulating between the patient pre-surgery and post-surgery, with obviously some quite large improvements post-surgery, which would in a degenerative condition certainly not be expected outside of an effective treatment. So there we are.